Bismillah ar-Rahman ar-Rahim. My talk today is going to be on cataract surgery in GIA, implantation of intraocular lens. Pediatric uveitic cataract has a relentless course. The challenges include controlling inflammation, reducing anatomical damage, reducing post-operative complications, and of course, considering good visual rehabilitation and the best refractive correction for these children. Unfortunately, the results of pediatric cataract surgery without uveitis cannot be directly applied to what we see for uveitic eyes. Why? Because we are dealing with a dual problem of inflammatory sequelae and at the same time the primary cause of inflammation. Tackling both affects the timing of surgery as well as the visual outcome. Visual recovery for these children after cataract removal requires that we overcome the triggers of inflammation, which are the primary cause of uveitis, flare-up from the surgical intervention, the presence of intraocular lens, and through the modifications in surgical techniques, testing the different IOL materials, as well as addressing the challenges faced during doing biometry for these children, we can achieve this. First, we start our surgery by doing a gonioscopy for these children in order to exclude the presence of peripheral anterior synechia, which can result in secondary glaucoma later on. The second thing that we use is the use of micro-incision surgical instruments, like using the 23-gauge MVR. We start our surgery by doing a blunt synecholysis in order to dilate the pupil and to reach an optimum size in order to be able to perform our capsulorhexis. And in many cases, we encounter a membrane that is adherent to the anterior lens capsule. This membrane can be actually simply detached from the surface of the anterior capsule and grasped using a micro forceps and extracted from the surface of the anterior capsule in order to be able to perform a complete and a rounded capsulorhexis. Most of the cases have white cataract, so we are in need of doing staining and doing a complete capsulorhexis. Sometimes we encounter calcification, as in this case, which may jeopardize the anterior capsulorhexis. The clue is to do a complete irrigation aspiration, removing all the lens matter. We sometimes need to do polishing of the anterior and the posterior capsule in order to remove any lens cells on the surface, and whether to preserve or to leave the posterior capsule, it depends on the age of the child. If the child is less than 5 years, then we do have to make a posterior capsulorhexis and a posterior capture. Now to the point of controversy, why we adopt IOL implantation. Removing the lens actually leave this child with a large refractive error, resulting in anisoconia that can result in deep amblyopia, and actually these children cannot be easily corrected with contact lenses, either due to that contact lenses fitting is difficult due to band keratopathy or because of the risk of infective keratitis from the steroids. Still, IOL implantation is controversial, although in 1996, Prost and Holland were the first to report the first IOL implant in these children, with improvement of the medical control of inflammation and the new surgical techniques and the more biocompatible IOLs attributed to the success. Taking care that band keratopathy affects the K reading, posterior synechia can affect the anterior chamber depth, the hypotony and the epiretinal membrane can affect also the axial length, so A-scan biometry is usually more reliable for these children. Optical biometry might not be used due to the density of the cataract and the age of the child. Studies have shown that the hydrophilic acrylic lenses have a good uveal but a worse capsular biocompatibility. Hydrophobic acrylic lenses had a low uveal but a better capsular biocompatibility. The round-edged hydrophilic acrylic lenses should be avoided because of the accelerated rate of PCO formation. To implant in the bag is the best option, and that's why we enlarge our incision and then we go for implanting a primary implantation in the bag, which prevents the chaffing of the iris by the IOL haptics and reduce the inflammatory response. The secondary IOL implantation and opening the leaflets might not be always possible because of the fibrosis of the leaflets of the capsular remnants. Remember that after the implantation, we have to go do an irrigation aspiration again for completing any residual lens matter, for removal of any viscoelastic that might be present. All these cases should be sutured after the surgery in order to avoid hypotony. And of course, don't forget that these cases require always to be injected with subconjunctival subtenon or subtenon injection of steroids, and of course, taking care of the post-operative care of these children. So, in conclusion, the most important prognostic factors for these children that will make us decide whether to implant or not to implant in all the previous studies were the patient selection and the control of intraocular inflammation. And the data advises for minimally invasive small incision cataract surgery with a hydrophobic acrylic lenses in the bag, especially in the unilateral cases. However, we have to stay also alert that each patient must be evaluated as a case-by-case basis during using extreme caution before the final decision is made. Thank you.